For the first session, to bat lead off, I'm just going to introduce some novel concepts, maybe some practical tips. We're going to talk about practical management strategies and hoping to inspire discussion. I don't think this is anything that I can solve. A lot of the things I put out there are questions that don't necessarily have an answer, or at least I will tell you my answer, but it doesn't mean that I have anything more than that. I need to acknowledge a couple of my fellows who would have put together the images and videos that you're going to see. We're going to start. Starting is with a novel classification scheme for chronic rhinosinusitis. I think we figured out for a long time that not everybody with sinusitis is the same, and we need something like tailored therapies to be able to differentiate these patient populations. I cited some European position paper data. There's very similar data that comes in ICAR recommendations, which are new as well. And really, as far back as a decade, we split people up into with polyps and without because it made sense to us that we could treat those patients differently. Unfortunately, it wasn't that simple. It didn't really, too broad definitions, broad treatment plans. I think that started to change. We've started to understand some of the mechanisms behind sinus disease and whether that's a barrier dysfunction, whether there's some kind of innate immunologic issue going on here. I think we're starting to learn more. And in 2020, the European position paper put out a new classification scheme, and in 2021, ICAR, even more recently. I always see these diagrams and they make me sweat a bit, and so really all it is there to show you is that we know that there's a pathway driven by eosinophils, Th2 cells, and call that type 2 inflammation. Everything else we're going to call non-eosinophilic inflammation. And I think that it means that instead of just having with polyps and without, we're starting to see a difference in terms of categorizing sinus disease, whether that's localized to one particular sinus, people who have an odontogenic problem and end up with an isolated maxillary sinusitis, or even more globally when we see the diffuse sinusitis patients, the patients who have sinusitis globally, but aren't the same. Some of it is driven by eosinophils, allergy, those kind of things. Well, let's call that type 2 or eosinophilic sinusitis. And the other type that is non-eosinophilic, more driven by neutrophils. And so the idea being that we've learned a lot in that process, but practically speaking, what does that mean? To translate that, that's really trying to figure out the difference between these two patients. One that has extensive polyps, inflammatory changes, not a lot of that thick secretion. The other one that has some kind of barrier dysfunction, a lot of thick secretions, chronic purulent infections. Those two patient populations are different and should be treating differently. How do we distinguish between them beyond that? Well, I've told you a little bit about the endoscopic appearance. You've seen the polyps versus the thick secretions, tenacious secretions. Are there things on history or serum biomarkers? Are there histopathologic ways we can figure out the difference between these two patients? There's a lot of people who have worked on this, and I won't belabor the data that surrounds it, but to try to figure out what are the predictors of eosinophilic rhinosinusitis. These are people who have asthma as part of their pattern, an atopic picture, have polyps. Furthermore, there are people who have gone so far as to review systematic review data of what it looks like histologically, people who have driven by eosinophils versus neutrophils, to try to figure out if we see so many eosinophils in our tissue samples from surgery that we can change how we treat these patients. Now, routinely, we've gotten the pathologists at my institution to get on board about please examine for the number of neutrophils or eosinophils at 400 times magnification, high-powered field, because we have data that lets us change what we're going to do to treat these patients. To make it more clear, I put out what I think was a good table from that exact same study that really shows characteristic symptoms. The eosinophilic population is the ones that I told you have an early loss of their sense of smell, have polyps when you look inside your nose, and can have thick secretions, but not necessarily that mucopurulent discharge. They're eosinophilic, they have a high preponderance of asthma, and when they look at their histology, when you take out polyps in the operating room, they have a lot of eosinophils. Conversely, that non-eosinophilic or neutrophilic population is the mucopurulent discharge people, not asthma comorbid, people who respond to macrolide therapies, and we're going to talk a little bit more about that. And so we've kind of been able to separate these patients into two groups and say, well, what is it, the difference between that eosinophilic and neutrophilic, and frame a bit of a framework about when you see that patient, which treatment pathway. Well, it's all of this is fine and good, but it's only going to be useful when we can treat them differently. And so in EPOS and in ICAR, we've come up with a lot better treatment algorithms. The idea being that everybody deserves appropriate medical therapy for sinus diseases, saline nasal irrigations, intranasal corticosteroids, education about the disease entity and compliance with their medications, because we know that That doesn't happen fast. Intranasal corticosteroids, they want them to work next week, and they just don't. But beyond that, can separate those patients into that eosinophilic type concurrent asthma who respond really well to steroids and do really well when you give them steroids. And then think about after that, if that fails you, including sinus surgery, steroids, then you have some things in your back pocket. We know they're systemic steroid responders. We know that potentially these people are ASA desensitization responders. We know the biologics work, but in this patient population, not the other patient population. On the flip side, what is it that we can treat that non-type 2 patients with? It's that long-term, low-dose antibiotic therapy. We used to throw both of these at people, a course of steroids and long course of antibiotics without really knowing which was which. Now we have a way to kind of differentiate and expect to see a difference in terms of their makeup. I put this slide in here to show you what I do, practically being able to identify those people. I give all those patients steroid-impregnated saline irrigations. I find it's a better way to increase compliance with my nasal steroid medications. I find that those patients, when they're putting steroids into their rinses, tend to do them more religiously. I find that they get the beneficial effect of the cleansing plus an anti-inflammatory effect. But then I really tailor their treatments to which side of the scheme they're on, understanding that there's a mixed picture in between, and you can't always tell which one these are. But anything that's anti-eosinophilic treatment after that, topical antihistamine preparations like Dymista, advanced delivery devices. We know these patients respond to topical steroids. What are better ways to get them inside the nose, like the exhalation delivery devices that you can see about in our exploratorium, ENT exploratorium. ASA desensitization biologics I've talked about. On the non-eosinophilic, what about that long-term low-dose macrolides? And it's one that I'm going to spend a minute talking about. And then those are the patients that maybe benefit from the atypical rinses. We've seen tons of data about mupirocin, betadine, xylitol, other surfactants that are supposed to help. I think the reason we haven't gotten great data about why it works or doesn't is we weren't picking out the right patient populations. And when we do, I think we're going to see success, because we all have patients that it works for. We need to select for them appropriately. The role of long-term low-dose antibiotics, I just wanted to talk to you about a bit. It's not really an antibiotic effect. It's partly an antibiotic effect, but moreover, it's that it needs to be an immunomodulatory effect. It's why it's used at a low dose. It's why it's used at a prolonged period of time, like 3 months, to try to get that effect, because it's an anti-IL-8 medication. It's going to block neutrophil chemotaxis and neutrophil release of IL-8 so that we don't get the same kind of effects happening in that neutrophilic population. So really, the macrolide antibiotics that are given in a slow dose over a long period of time are really immunomodulatory medications, because steroids aren't going to inhibit IL-8 function, and it explains why those patients don't do well on steroids. The Cochrane Review has kind of put out a summary document based on the guidelines that say that, in patients without polyps, presumably that neutrophilic population before it was named, 3-month courses of macrolides can help substantially. And when we look at who they help, it's the exact same list again. Before it came out, low serum IgE, low eosinophilia, no asthma, poor response to steroids. We know who this patient population is. It's that non-eosinophilic population. And so if we change gears from thinking about what these 2 distinct groups are, understanding that there's a mixed group that sits in the middle, and the treatments that we can employ, what about decision-making at sinus surgery? As a whole other concept, what if these medical treatments fail? Well, I'm going to use a case to display that. This is a healthy 45-year-old woman who I met who had a 10-year history of obstructed nasal breathing, congestion, postnasal drainage, facial pain, alterations in her sense of smell. She had a history of asthma that was ongoing, had eczema as a child, and her endoscopy revealed moderate edema with thick, clear mucus, no mucopurulent discharge, no polyps per se. When we look at her scan, we see disease throughout her paranasal sinuses, somewhat patchy, involving all the sinuses, but not completely opacifying any. In summary, she had a 10-year history. I scored her Lund-Mackay score as a 15 out of 24, and she had global edema, but nothing sinister on examination. Well, what's going to help us proceed with the decision-making prior to proceed with surgery? A lot of questions abound about the Lund-Mackay score. I gave it to you because it was an easy way for us to talk about severities, that she's a 15 out of 24. It makes us understand objectively what that means. We have to know that there's not really a great correlation between those radiologic scores and their symptoms. People can be all over the map. We do know, however, though, that higher Lund-Mackay scores correspond to people having more surgery, and that those people with higher Lund-Mackay scores end up with better or bigger postoperative symptom improvements and less revision rates. And so beyond just radiology, using something like this, a SNOT-22 score, is a nice way of quantifying that symptom burden so that gives patients a way to tell you about exactly where they're at. I'm still stuffy, but it's a little bit better than before. I think this does a better way of trying to examine that. Some of the things that are worrisome is the flags that make me not want to proceed to surgery is people who either have atypical facial pain, and I think you've heard this from a number of people, is operate on pain, get pain. Try to understand that which of those patients are the ones that are having non-sinugenic pain, or the people who want surgery to stop using the medication. And this part is a common thing I hear in my office, and that goes back to some of the instructions around this is an understanding it's an inflammatory condition, you're going to need to continue to use those medications. Maybe we get a reduction when we do good surgery and we get sinuses healthier again. So I elected just to continue with this case is that to start her on topical therapy, see her back in a couple months. At her 2 months, her symptoms are improved, but she wasn't quite happy with her quality of life. I did a SNOT-22 at both of those occasions, and she got a substantial reduction, just not one that made her that happy, 33. Together, we elected to proceed with sinus surgery, and I guess the question then becomes, what is the extent of aeration we want to see happen at sinus surgery? What is involved in the decision-making to determine the surgical plan? And I'll tell you, my personal philosophy is we have huge revision rates associated with sinus surgery. There's evidence to suggest that 50% of patients will require revision surgery. The reasons for that are complex and multifold. Severity, inadequate aeration of some sinuses. But what it's really led me to do is more comprehensive primary surgery, because the more problems I see are from too little than too much. And I haven't seen very big problems with big hole surgery. What does comprehensive sinus surgery mean? Really, the removal of all partitions that we're going to do in the lab tomorrow of the ethmoid cavity to skeletonize the orbit and the skull base, to end up with this kind of picture. Schematically, what that looks like is leaving the middle turbinate intact and then removing all the partitions from between the orbit, skull base, and that turbinate. It turns that view into that view so that we can achieve good aeration of those sinuses, good penetration of the medications that we're going to give them. Schematically, in the sagittal standpoint, you can say, well, I can open into all those sinuses, but not necessarily skeletonize them. The problem becomes that what happens? Does medication get in there when you're using nasal steroid sprays? Maybe flushes, sprays. What about scarring and stenosis of those? Is that what's going to result in our needing revision surgery? And so skeletonizing them right back to the skull base and the orbit can lead to improved ability to be able to flush those cavities. And so the rationale is that we're going to get improved outcomes and reduce our revision rates, both from reducing the inflammatory load, less surface area, less inflamed mucosa, less release of inflammatory cytokines, overcome that mucostasis, turn those cavities very flushable, and allow maximal penetration of the topical medications that go into it. And there's a lot of good data to suggest that that kind of approach, as long as it can be done without complication, is going to lead to less revision rates. It also means that complete or comprehensive surgery is an independent predictor of an improvement in SNOT-22 scores, exactly what we want for our patients. And so I elected to perform a comprehensive full house sinus surgery in this patient. She started topical therapies again and didn't use systemic therapies. Here are her postoperative outcomes. An open cavity where we can see directly through that ethmoid complex to the sphenoid, right into the sphenoid, still some polypoid change inside there. We can see the anterior ethmoid artery skeletonized at the skull base, a close-up of it as well, looking right up into the frontal sinus so that I know flushes can get up there and I can surveil that space in clinic. On the right side, very similar thing, seeing into that ethmoid cavity all the way back to sphenoid, anterior ethmoid artery, and then the frontal sinus is particularly a small pocket of an intersinus septum. Well, what are the practical tips that I have to getting us there? I think that there are some things that I would say help me get to where I feel like I can do that in every patient. What are those? Well, there's some things that I've employed over 10 years to see better. Good surgery happens when I can see better. And the reality of that comes to, I've broken it down into 4 things that I do to set myself up to see better. One of them is the ergonomics, really positioning. I make sure that I don't have strain on my arms or on my neck. You see screens like this or like this, and I had a lot of trouble in fellowship because we had a screen that was put at the center of the bed, shared between 2 surgeons. I think an important thing for your own health. Reverse Trendelenburg, putting the patient in head up, and I'll put a shout out to one of my UBC colleagues who published a paper on head up surgery, really improves our ability to be able to see because the mucosal oozing is better. Packing the nose with 1 in 1,000 adrenaline. The vasoactive material that we do there, I think we can use safely in the nose, and our ability to be able to see after nasal packing improves. And then injection. I inject in several spots. I think this actually helps with postoperative pain control and may have a role in additionally in our intraoperative visualization, although I do think the packing with 1 in 1,000 adrenaline has a better effect. Improving visualization can come in as simple as things like warm saline. If I ever get into a cavity which I feel like I can't see because of that mucosal losing, that's exactly where I'm going to start to try to get some improvements in what we're going to be able to see. And you can see the difference. You get to start to see the mucosa again, start to see where some of those ridges that are going to create the problems. One of my other practical tips or pearls is about the septum. Improving your access through septoplasty, I think, just makes my life a lot easier. And there's a lot of situations where in the past I think that I hadn't addressed septums because I could work around it. I don't do that anymore because I think it improves my surgical access. It creates mobility on the side you're working on, and then on the other side when you're working. It allows for easier instrumentation that way, especially when they're frontal sinus. And then afterward, it improves my topical medication delivery, especially to the olfactory cleft. Here you can see that typical septal swell. I can't see into that olfactory cleft, and I can't see the armpit of the turbinate. And when I address the septum, and in this case concas, I can see right into that olfactory cleft, and more so, medications postoperatively can get to that space. Moreover, when we're working in the sinuses, this is that septal mobility. I'm able to move the septum during work on that side. And then particularly when we get into using angled instrumentation for the frontal sinuses, you can see I'm exaggerating the point by using something against that septum to try to get right to where I can put tools and visualize directly up into that sinus. I think that there's some good data that you get a septoplasty concurrently with sinus surgery improves SNOT-22 scores. That's in all comers. It's interesting to see that that translates into an actual difference in patient outcomes, because you'd think it makes your surgery easier. It was impressive for me to see that that makes surgery outcomes better. Maybe this case doesn't need a septum, and I just showed a video here that I will skip through reasonably quickly just to show that it's not bad. We can still get access. I can see the root of that turbinate. Maybe the same thing as we get to the other side. I'm seeing that root of the turbinate. I elected to perform a septoplasty, partly also because this patient had complex anatomy in their frontal recess, but I was interested in the after. With the adage of think septum, do septum, same patient, our ability to see up into that olfactory cleft and what's going to be the topical medication delivery there is just as important. And so I think that those pieces of the puzzle are part of what gives you the answers. One of the last ones I will tell you about is, I think, mucosal preservation. I am interested to make sure that we all see that happening. That happens really quick. When we're using a microdebrider in the sinuses, there it's gone. Part of the skull base, most of the orbit, all that mucosa gone. The consequences of that are intense osteitis, granulation tissue, hyperostosis, and scarring. Well, what does that mean? Practically speaking, all that means is that we're going to get scarring that happens. This is the same patient, pre-op, operated on elsewhere and sent to me, and then post-op, stripped in that place immediately adjacent to that frontal recess. And so we can see that that creates complications that occur as a result of it. And so what I will tell you is that all those things together, I think, is what leads to careful, comprehensive assessment of the patients and the idea that we can tailor their treatments together and going to let us have cavities like this and continue to have them so that they can deliver medications to there and make sure that we can get ongoing, consistent, careful, comprehensive sinus surgery results. I'll end it there so that we have adequate time for questions so that we can make sure we get a further discussion about any or all the things that I've talked about.